Hello, students. This is uh, this is a presentation on pain, and this is one of the other important topics besides fluid and electrolytes. And if you look at your Potter and Perry book, um, the chapter on pain is almost 30 pages. Now, in that chapter on pain, in your Potter and Perry, there is certain sections which are very important, and this presentation will highlight those sections. I will also, when the time will come, I will also ask you to open your Potter and Perry book, and I'll make you highlight those things from the book, which I want you to, you know, uh, put special focus on, while preparing for the exam. Um, Pain, by this time, because all of you have been taking vital signs a lot, by this time you all know that pain is a fifth vital sign. It's the fifth vital sign, and of course, it is a subjective response to anything happening physiologically or anything if there is any psychological stressors if the patient has. So, pain can, it is a subjective response, and it is a response to physical and psychological stressors. And all of us have felt pain at some point or the other in our lives. And although pain is unwelcome, it often serves as a kind of warning, of potentially health threatening conditions. And each pain event or with each patient is a unique personal experience. And pain is the most common cause why people go and seek help of doctors. Because pain is subjective, pain presents a lot of challenge to nurses. Usually nurses, they assess clear objective data, that maybe the patient is showing, his skin is turning pale, or he has a low pulse, or his heart rate is increasing. But in assessing pain, the nurse must, she must rely on the patient's description or the patient's non-verbal cues to which can show what kind of pain patient might be having, what type of pain patient might be having, how long he might be having this pain, and what is the intensity of that pain. So it's not only the objective data, but not only the objective data, but also the subjective data is very important when nurses are assessing pain. And pain management is a very big topic in nursing, and many research studies have been done on pain management. Many people have done their PhD on pain topics. So it's a very wide topic, and it is taught in all healthcare schools. So it can be taught in a medical school, it can be taught in a nursing school, it can be taught to RNs, LVNs, so it's a very vast topic. But there are certain important things which this presentation will highlight, which you as a future RN should be aware of. Often doctors and nurses, they do not understand the concepts about pain management, and the doctor or the patient, they might fear that if I take a lot of pain medication, there is a fear of addiction. If in fact the nurses or her own opinion can positively or negatively affect how a patient's pain should be managed. And because pain is subjective, the nurse may judge whether the patient is actually experiencing pain, and this is not the part of nurse's role. So it should not be based on your personal judgment. Nurses have an obligation to react positively to the patient's report of pain, and there is a responsibility involved to minimize pain. Now, and because there was under treatment or not much of diagnosis of pain was happening, or people's perception and judgment was clouding this whole, it was uh, kind of uh, you know mm, whatever the doctors or nurses, they had their own opinion about pain. It was stopping them from treating or taking care of patients who were suffering from pain. So that's why pain was given very heavy stress as fifth vital sign. um, and standards for pain assessment and management in our country is developed by the American Pain Society and also the Joint Commission. They both regulate standards, of how to assess pain and treat pain. Uh, and Pain for many people is a major problem in their life, and it reduces the quality of life. And the financial impact of pain is too much. In the United States, unrelieved and inadequately managed pain costs an estimated $100 billion each year as a result of longer hospital stays, rehospitalization, and visits to many outpatient clinics. And as I said earlier, nurses have a central role in assessing and managing pain. Now, the first slide, it's telling you the thing about your own experience with acute pain, chronic pain, how you responded to that pain, what were the measures you took to relieve that pain, and what effect did it have on your daily activities. When I say it reduces the quality of life, it means that the patient, because he's so much involved in this, tackling his problem in life pain, that his other activities of his daily life will get heavily influenced. So just do this critical thinking challenge, and we'll discuss about this in class. I'll just ask for your experience, how did you handle it, or, how was your response? This is just a kind of a thing for you to do as a research, Um, and let's go to the next slide. Now, the next slide is based on sleep. I'm not going to explain this slide because I will be giving you a handout on sleep, and that would be sufficient enough for you to go through. Okay, now let's go to the next slide. Now, pain and its influence on homeostasis. And when we are talking about homeostasis, it means the internal environment of patient's body. So when pain, there is a definition on the slide. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Now, this is the definition given by International Association of Pain. There is some. Uh, there is another definition of pain as whatever the person experiencing it says it is, and it exists whatever the person says it does. So there can be various definitions of pain. My focus is not for you to memorize the definition of pain, but to understand the element of subjectivity involved with the definition of pain, and how it can uh, put some stress on patient physiologically and psychologically. Um, when the pain is not treated, there are many consequences of untreated pain. Patient can have unnecessarily suffering, and he might become dysfunctional, you know, psychosocially or physically, and his sleep can get disturbed big time. And uh, and if there is an acutely ill patient on your med surg floor, if his pain is not relieved on time, it can it can also show some symptoms. You can see his unrelieved pain affecting his vital signs. His heart rate can increase, his cardiac workload can increase, his he can have high level of muscular contraction, spasms, also low GI, low digestion, less peristalsis happening. So this means that untreated pain can easily affect all body systems inside the body and can affect patients' homeostasis. Um, this slide also tells you about types of pain, acute versus chronic. We will study this in the subsequent slide. And the difference between the acute and chronic pain is very well given in your Potter and Perry book, and I'll be highlighting that table for you. Um, it says next. It says awareness about nursing providers' belief. Um, Now, I don't think I need to give much explanation. Is this much explanation in this? Basically, when they are saying nursing providers' belief, it means that how much competency you have to assess and treat patients' pain. And this competency is not only the skill level, but it's also the competency to understand, the importance of pain assessment. Do you have that expertise? You know, do you have within you false concepts of addiction and tolerance? Let me give you an example. Suppose uh, you are uh, on a floor, and a patient is saying that you just gave me Norco, one tablet of Norco, and I'm still feeling pain. And he says you 15, maybe he says you at 9 o'clock. At 9:30, he's in the morning, he's saying it again, and at 9:40 he's saying it again. And you discuss it, because you are a new grad RN. You discuss it with your colleague, and she says, you know what, don't worry, he's a frequent flyer. Anytime he's on the floor, he always asks for pain medicines. He's a substance abuse patient. And you say, oh. And then you know what, you ignore this patient's request, and you continue with your daily life. Now, this is where the perceived importance of pain assessment is very important. What will a prudent nurse do? When I say prudent, prudent is PRUDENT. A prudent nurse will assess patient's pain level using whatever tools she has, and she will make sure that she communicates with the doctor that whatever prescribed pain medication is there, it's not helping that patient. So adequate assessment and then adequate communication to the doctor becomes important here. Also, when the doctor gives order, the nurse needs to ensure initiation of adequate pain relief measures. Also, she needs to know that when she needs to intervene and how she needs to intervene. And last, the most important thing that she needs to do is she needs to advocate for those in pain. So that's what, awareness about nursing providers' beliefs will also include the nurse's expertise, her knowledge, dimensions of health that impacts pain. All aspects of health are affected by pain, and the pain can have, as I said earlier, it can have those both, physical and psychological effect. Patient can be psychologically, patient can show a lot of anger, fear, depression, anxiety, and it can negatively affect patient's quality of life. And suffering can result in a profound sense of insecurity, and patient can feel that he's vulnerable, he has lost control over his life. And many patients can also experience spiritual distress. And And when you're thinking about pain, whenever I'm talking about pain, think about those cancer patients for whom pain is a daily thing, you know. So it's very important that you know the that to understand so many factors which are involved behind pain. Physically, it's not easy for you to make it out because you will get the information through the objective data, but the psychological effect is also very profound in patients suffering from pain. Um, mhm. Now let's go to the next slide. Okay. I don't know what happened with the slides, but this types of pain, when I posted this PowerPoint, it will show you clearly. This slide has types of pain and it just says acute pain, chronic pain, cancer pain, non-cancer pain. Now, in your chapter on pain in Potter and Perry, they have classified pain, and you can classify pain by its underlying pathology, which really highlights the physical cause, or you can classify pain by duration, the amount of time it lasts. By underlying pathology, it's called nociceptive pain. Now, here I would like you to understand the key term, nociceptors from the book. You uh, they are sensory receptors for pain, nociceptors. So, when pain is classified by underlying pathology, it's called nociceptive pain. And when pain is classified by its duration, then it's called acute pain or chronic pain. Now, not uh, when pain is classified by pathology, there is another term given is also called neuropathic pain. So it can be nociceptive pain and it can also be neuropathic pain. Um, Neuropathic pain is a type of pain which you usually feel as burning or tingling, and it results from direct stimulation of nerve tissues in your central nervous system. So, neuropathic pain is a type of pain which you usually feel as burning or tingling, and it results from direct stimulation of nerve tissue of the central nervous system. Let's go back to nociceptive pain. Nociceptive pain, as I said, it's stimulated by various uh, types of injury done to body tissues. And nociceptive pain examples include sprains, bone fractures, burns. You know, burns is the same word which I spoke in class, and most of the people didn't understand. So burn, when somebody get burns in fire. So burns, bruises, or there can be an inflammation, like in arthritis, or there can be some kind of any kind of pain which is going in your body tissues. So that's is nociceptive pain. And I told you the examples are sprains, bone fractures, burns, bruises, inflammation. And nociceptive pain is usually time limited. So, meaning when the tissue damage heals, the pain will typically resolve. Um, Another characteristic of this nociceptive pain is that it tends to respond well to treatment with opioids. So, if you have uh, pain medications with the category of opioids, it tends to respond very well with this treatment. Uh, so now, in for the exam purposes, I want you to know just what is the nociceptive pain and what is the example of nociceptive pain. Um, and nociceptive pain is the type of pain which is classified by underlying pathology. Neuropathic pain is also pain which is classified by underlying pathology. And nociceptive pain example I told you, And neuropathic pain, you know, I also told you, is pain which is usually felt as burning or tingling and resulting from direct stimulation of nerve tissue of the central nervous system, or it can be also the peripheral nervous system. Neuropathic pain is frequently chronic, and uh, but and it can be handled to some extent by opioids, and but mm, but they are not fully reversible. So that and this pain comes under neuropathic pain comes under pain by underlying pathology. Now let's talk about pain classification by duration. There are two kinds, acute and chronic. And during my clinicals, I've asked my group, and they were very well aware of this kind of pain. And the difference between the two kind of pain, acute and chronic, it depends on its cause, its course, its symptoms, and its treatment. Acute pain is has a sudden onset. It's less than 3 months time, and it's which is mild. It has symptoms which are really mild to moderate. And examples of acute pain can be somebody having pain after a surgery, or post-operative pain, labor pain, or pain from some kind of trauma, fracture, sprain, and or angina pain. It is there, but it goes away after some time. Um, and for acute pain, simple analgesics for symptom control is okay. Analgesics can easily control their symptoms. And acute pain, of course, diminishes over time as the healing happens. And if acute pain does not heals over time and it persists for some time, then it can become disabling chronic pain. Uh, now, uh, let's talk about the chronic pain. Chronic pain is the opposite of acute pain. It stays for a very long time, and sometimes it affects patient's quality of life, and it's usually uh, part of patient's life for a it's usually uh, handled with high level of painkillers, and it can last longer than 6 months. So chronic pain can last longer than 6 months, and there's sometimes there not be an identifiable cause, and often it is unresponsive to conventional medical treatment. So simple analgesic medicine cannot help this pain, and it is more complex. People with chronic pain are often depressed, withdrawn. They don't want to mix with society, or and they just want uh, to shut themselves up. Um, no, remember in class I talked to you about a woman who was married to um, a pastor on my floor about whom I was taking care of. She was suffering from pain from multiple sclerosis, and she wanted to end her life because she was depressed from the years of pain. So that's the woman who's suffering from chronic pain, which have lasted longer than 6 months. Um, arthritis, the common disease which we have, that has a chronic pain element. Some people have low back pain. Some people have migraine. Migraine can be very debilitating, and then in some and the bottom line is that it cannot be eliminated. Chronic pain cannot be eliminated, but treatment focuses on helping the patient cope with the pain and be as functional as possible. um, Now, it's very important for you to know that In chronic pain, sometimes the pain areas are hard to identify. Your pain may have no foreseeable end, I mean, it will stay with person all his life. And while in acute pain, you can see some autonomic responses like blood pressure, pulse, and respiration. They're increasing. Pupils are dilating. Skin is diaphoretic, which that means it is sweaty. It's pale, cool. In chronic pain, if you talk about autonomic responses, vital signs can be normal, pupils can be normal, and skin can be dry, warm to touch, and normal color. So that's why chronic pain becomes very complex. Um, People who have acute pain, I mean, you can see their facial grimacing, they are guarding themselves, they are crying. In chronic pain patients, there is always some sense of depression, hopelessness, frustration. They sleep less, they have low appetite. So, this is some remarkable differences between the acute pain and chronic pain. Let's go to the next slide. Acute pain, yes, there is an activation of sympathetic system. So I told you there is an activation of autonomic responses, increased heart rate, pulse, respiration is there. It's the same thing which I said, how the patients respond to acute pain. Their autonomic responses get activated. In chronic pain, it is gradual. It's you know and its pain is lasting more than 6 months, and the pain areas are hard to identify. Vital signs can be normal. So I really want you to read this differences from the book Acute Pain and Chronic Pain. Um, let's go to the next slide. Now, when you type on Google ATI pain management, it will open up a page. And on that page, I want you to read uh, pain management, under pain management, pain assessment, whatever is written in ATI about pain assessment under the topic pain management. Okay, it's what it will give you a standard, you know, way of pain assessment. Now PQRST, usually pain how pain will be assessed by a nurse is done on basis of this mnemonic PQRST. P stands for, there are, what are the precipitating or palliative uh, factors behind pain. So you will ask patients that, what happens, what causes your pain, or what makes your pain worse and what helps to relieve the pain. So precipitating, what aggravates the pain; palliative, what relieves the pain. Quality of pain, how does it feel like? So you will ask the patient, what is the quality of pain? Do you feel like as if something sharp is going inside you, or you feel like stabbing pain, or as if somebody's crushing that body part, or that area? So for quality, we use terms like sharp, stabbing, crushing. Also, this PQRST is all on your EMR. When you go to your hospital, you look at the pain assessment, they have all the pain assessment, uh, you know, uh, explanation, all the documentation, all based on this PQRST. Or is regional radiation where the pain is happening, and does it spread to the other areas of the body? And then severity scale, does it limit any activity? Is your activities of daily living getting affected by it? Timing, how long does it last? It is chronic or intermittent. Now, intermittent is very important word in nursing floor. Intermittent means on and off. It comes sometimes and it goes away, and then comes sometimes and goes away. So this is very common criteria for pain assessment. Now, this slide shows you some pain assessment tools. And the first is visual analog scale. And visual analog scale is just a kind of a line where the 0 means no pain and 10 means the worst possible pain. And you have to ask the patient that how will you rate your pain, and then you categorize his pain as mild, moderate, severe. And as you categorize his pain as mild, moderate, and severe, that will decide what kind of pain medication doctor might have given for him. Also, there is a word descriptor pill. If you can connect it, then there is also a word descriptor scale. Now there is a faces scale. Faces scale is, you will see all around on the hospital floors all this pain assessment scales posted, and it's very clear. I think faces scale is very good for people who cannot understand English or the language we are speaking. We can show them this, pictures. Verbal scale is almost the same thing. Functional pain scale. Functional pain scale is how it affects your activities. While you're having this pain, can you cook? Can you do gardening while you're having this pain? Can you talk on telephone? Can you watch TV? While you're having this pain, can you even talk? So this is the functional pain scale, which will highlight on the patient's how this pain is affecting patient's daily life. Let's go to the next slide. This is again different pain scale. Um, Now this is mm, now how why do you think this pain scale? How a teacher might test you? Uh, we can test you by by patient saying something which highlights that the pain is of moderate level, and for moderate level of pain, the you know the patient is asking for IV morphine. IV morphine is usually for severe level of pain. So that's how this scale helps, you know, nurses. So if I have to ask you a question, it might be on one of those, focus. You know. So understanding the severity of pain is for the nurse is very important, because that's how she will select the pain medication, because sometimes the pain medication order is as needed. So if you're not able to assess properly the patient's pain level, how will you decide at what kind of pain medication he might get from the stand from the from the PRN orders? Now this is kind of a crowded slide, but the diagram is very good. And the diagram is what it's telling you is that you look at pain, in the middle, and then there is objective data. You are looking at PQRST. There is another thing called Quest, which is again is showing how you can get the objective data. You can also do the objective data by taking patient's vital signs, his verbal, non-verbal behavior, his mood, and then it says nursing diagnosis on the right, anxiety, alteration, comfort, fear. Then it says you're doing analysis, you are planning, you are implementing, and then when you are implementing, maybe you can try some non-invasive pain relief. Non-invasive pain relief is can be some of the ways with distraction. Music is a good distraction, cutaneous stimulation, relaxation techniques, and there are some in the book: biofeedback, acupuncture, and all that. So if you relax the patient, his pain level goes down. If you come move more towards left, they will tell you about different kind of classifications of medications which are used for relief. PCA, which is patient controlled analgesia, narcotics, morphine, you know, Dilaudid, Oxycontin. Then there is non-narcotics, Tylenol, acetaminophen, and NSAIDs, ibuprofen. Then there is around the clock dosing. Um, Around the clock dosing is that every pain medication after some time will have its effect dying. And if the patient has one main pain medication scheduled to be given at 9, another pain medication scheduled to be given at 4, then in between, what if the effect of the medication given at 9 fades away? So in between, to manage, that in between pain, the doctor might write some other, maybe little milder pain medicine to manage that in between pain for the patient, and that is called around the clock dosing. And around the clock, I want you to see in your patient's profile on the floor if there is an order which says this pain medication is given around the clock, and then you research with the nurse how she's doing it, how she's giving that medication. Then evaluating, of course, if the pain is being affected, if your pain medication or a treatment or care is being affected. If you go towards left, um, then it also shows you the coming back to the same thing, how you will assess pain, what are its qualities, patient's history, his location, and all the on what is the meaning of pain for that patient. um, there's a clock there, and it has some symptoms showing abdominal distension. The causes can be the abdominal the causes can be the sometimes there is abdominal distension, full bladder, the cause of pain, abdominal distension, full bladder, surgical discomfort, or there is an IV which has infiltrated, or there is any tube on the patient's body which is non-patent and it's causing patient's pain. So this is a very kind of a quick snapshot of all the elements surrounding pain. Nurses have very clear role, and we talked about this. We talked about this earlier. We have to use our nursing process to, assess pain, accurately and treat it on with doctor's orders, and then take care of patient afterwards. Next slide is on patient control analgesia. It is um, it is a way of giving pain medicine to the patient where the patient has more control over that, when he wants to give medication to himself. But it is not done um, just by patient. It is done through the intervention of doctor and nurses. And it is a method of pain control designed to allow the patient to administer preset doses of an analgesic on demand. So there are preset doses, and if you see this, you see this slide, this is the PCA pump, patient control analgesia pump, and the arrow where it's showing, and you see there is a small, more there is a not small, a big morphine syringe. Maybe it's a morphine syringe, or it can be dilaudid syringe, and this is where the nurse, you know, uh, fits in the syringe. The one the the one end of the syringe will be attached to the tube, catheter tube, and that is going inside the patient, and then there will be another end of the tube which will have a kind of a small device on which has a one button which only patient is supposed to press for himself, not his family members. And then on the screen, on the pump, there is a there is a particular way where the nurse will enter doctor's order, so only that amount of medication is given to the patient. Now, risk of patient due to medication errors is 3 to 5 times higher in PCA than any other methods of medication administration error. And this happens because sometimes there can be over sedation, and respiratory depression can happen. Opioids, the class of pain medications known as opioids, such as morphine, dilaudid, and fentanyl, they depress brain signals to respiratory muscles. And sometimes in large post anesthesia K units or post surgery K units, nurses are overworked and there are more patients to less nurse ratio. Maybe one nurse is handling three high level, high acuity patients, and then vital signs, O2 sat are not checked often, floor is very busy, there is no centralized monitoring happening, and then, error happens. And um, there is, I think in a skills lab, there is, time will come when you will be showing how the PCA pump works. And this is all done by RN. And when the doctor's order is being loaded onto this pump, it's being programmed according to doctor's order. Two RN check is there for this PCA pump. Two RNs have to check independently that the dose is being entered correctly in this pump. Um, RN needs to be extra vigilant with these PCA pumps. And when many situations when I see nurses working two shifts, or they have, they're coming on Monday and they had a busy weekend because they were working another job, or they had some family thing going on, they had some family issues, or any other thing going on, and they're still on their mind and they're physically or mentally exhausted, the chances of, and they are handling now the PCA pump, the chances of, medication administration error becomes high. So anytime in your, life as a professional registered nurse, I would never, anytime in your life as a professional registered nurse, I would never like you to, you know, be as, exhausted as this nurse. Um, I think you will have to devise your own ways of de-stressing. And I think one of the most popular method among nurses is, it's going for, doing something with their family, like playing with their kids, or going for movies, reading books, or also yoga. Yoga, I think, is the best way to de-stress. you know I think I started yoga a while ago, and don't ask me how much my body gets sore with that, but I really like the breathing exercises. So I'm a new yoga learner. So yoga came from India. It is in my country. It comes from country. India has given yoga to the world, but I never was fond of it. So, but that's a very good way of de-stressing, all that breathing exercises and meditation. Okay, let's go to the next slide. It's a nursing assessment and history of pain. We need to conduct a complete pain assessment, verbal versus non-verbal, know the common indicators, obtain patient history. Has the patient used any pain medication before? What kind of medication he was using? Was it being effective? If he has any allergy to this pain medication, his own attitudes and beliefs, his maybe because of his social, financial, or cultural background. So that's important to consider. Next slide. Older adults are at great risk for undertreated pain. um, they can have their own opinion about, pain, that if I take so much of pain medication, I'll become addicted to it, that I'll develop tolerance, and or they have own belief about that we are very sensitive to pain. um, Now, one thing, when I see this slide and I see the word older adults, I'm thinking about, how due to aging, how their metabolism is slowing down, so everything will slow down. And on top of this, their respiratory depression due to PCA, will be little higher as compared to adults, because of their normal metabolism slowing down. Now, On the next slide, it tells you the considerations for older adults when you are giving them pain medication class, which is known as opioids. So it says start low and go slow. So anytime you're giving opioids to these older patients, go on low dose. They should start with low dose of that medication, and then you go slowly, and you use in the beginning no more than half of the recommended dose. And you should constantly evaluate patient response. And older adults, they feel moderate and severe pain as much as younger adults, but you have to assess before giving them any opioids. And believe me, if they are naive, like naive, new to this pain medication under opioids class, you will see a lot of nausea, vomiting, a lot of other problems happening. And usually, when these adults are given, older adults are given opioid for first time, they should be backed by, uh, nausea, vomiting, anti-nausea, vomiting medicine, or maybe, laxatives, because they, as it is, the constipation is very big with pain medications, and it will be much, magnified for these older adults. Okay, next go to the next slide. So, how you will do the diagnosis of acute versus chronic pain? Uh, Planning will depend on the patient history, his age, mental status, culture. It's one of the same thing. And then when you have to do action about this, it varies from patient to patient. Patient and family teachers is important. That when a patient is alert, he can tell you what is his pain number, and when and it is his job to request the pain medicine, or if he has that pain patient control analgesia, he's supposed to press the button, not his family members. And then also, you should always teach patients about the major side effects of the pain medication you might be giving. And when the patients are going with any order of pain medication home, then the discharge instructions by nurse should also be very clear. Um, let's go to the next slide. There is W Health Organization analgesic ladder. This is a standard, parameter which is given by the World Health Organization to, the healthcare providers, that how you should use painkillers, opioids for patients. So level one is one to, I think this is in your book also. Level one is 1 to 3 rating. If the patients have pain of 1 to 3, then you use non-opioids. Non-opioids maybe acetaminophen, or NSAIDs, aspirin, uh, ibuprofen. Level 2 is when the patient says, I have pain from 4 to 6, then you use weak opioids, or you can use with some adjuvant drugs. Now, weak opioids can be codeine. Okay, when I'm saying adjuvant analgesics, it means they are drugs with some other purpose. They were supposed to be indicated from some other purpose other than handling pain, but they are being also used for pain, to handle pain in some conditions. One of the drugs which is used is SSRI. The class of drugs is SSRI. SSRI is from coming from a neurotransmitter in brain known as serotonin. Now, serotonin in brain is related to mood, your sleep, your learning, social behaviors, and the SSRI is serotonin, selective serotonin reuptake inhibitor. So it means that um, SSRIs block the reabsorption of this neurotransmitter in the brain. So serotonin is a neurotransmitter which might affect patients' mood, his social behavior, and his something to do with depression. So when you block the reabsorption of serotonin by the brain, you know, Then you want to give that patient a class of drugs which are known as SSRI, which is selective serotonin reuptake inhibitor. And this actually belongs, this purpose, the primary purpose of this drug is antidepressant. So SSRIs are called selective because they primarily affect serotonin and not any other neurotransmitter in brain. So sometimes SSRIs can be also given in combination with the weak opioids to handle patient's pain. AEDs, anti-epileptic drugs. Anti-epileptic drugs, which very common are Dilantin and Keppra, and sometimes they are used for pain management, but I have not seen much of the evidence-based research on this. Strong opioids, when their patients says I have a pain level from 7 to 10, then you can give them strong opioids. And strong opioids are Dilaudid, morphine, oxycodone. So this is the WHO analgesic ladder. And I want you to look at this from the book also. Now, equa, equi analgesic chart. Equi analgesic chart is posted, I have seen in almost all the hospitals in and around their medication room. So it might be inside the medication room or outside the medication where the nurses can easily see it. What it's saying is that suppose patient comes patient comes and he is saying that, you know what, I have my pain is not being handled with uh, codeine which the doctor gave me. I want you to give me, Dilaudid. And that's where this chart is very important. It's it's telling you that how how the how if how one painkiller is different from another painkiller by looking at their half life, their bioavailability to the body, depending upon also their route. So now it says that 10 milligram of morphine is equivalent to 30. Oh my god, I'm not able to see this properly. It's a very small, it's a very small chart. Um, it's trying to tell you that, you know what, just because the patient wants higher dose of medication with higher strength, if patient wants higher strength medication, you know, just because he thinks that this is not being handled, that his pain is not handled by the lower strength other kind of pain medication, then you cannot just give him, the doctor cannot just give him the highest strength medication which he's asking for. Doctor has to look at this chart and say how much strength or how much effect, second medication will have on the patient's body as compared to the first medication, and how potent, that means how toxic or fatal that dose can be for the patient, of course looking at his diagnosis, his age and other stuff. So this chart is very important, and the nurses, what they do is, they also look at this chart by assessing that whether the doctor, if doctor prescribes the same amount, um, if the doctor is prescribing a certain narcotic, in a different route and a different strength, how it will affect the patient. The chart helps to ensure that the equi-analgesic doses of different narcotics given by different routes will have the, you know, how it will have same how it will have what kind of effect it will have on the patient. So it's very important, and even the from equi-analgesic, from looking at this chart, it's kind of telling uh, what how this milligram of codeine is equivalent to this milligram of methadone, or how this milligram of norco is equivalent to this milligram of morphine. So, and there is a very good small YouTube video explained by somebody, and I think that will help you to get a clear picture. Um, when we are discussing this, when the time comes, then I will tell you to look at that video just to get some idea, that why this chart is being, made. And this is also in your book. You know, I'm not asking you how much is, how much of morphine is equivalent to how much of codeine and what is the but I want you to know that what level of opioid or what level of narcotic a certain medication is, how how potent it will be for the body, or how strongly it will affect patient's respiration or something like that. So I want you to be aware of that. Um, let's go to the next slide. Pain and the role of the RN. Non-pharmacologic interventions for pain management. We talked about this in chart. Effective pain management and barriers, cultural context of pain. Then pain management is a big part of hospice, palliative, and also pain clinics. There's some handouts which I'm supposed to post. I will post that. Okay, so next, for the next slide, this is a question, and there is also an answer on the, there's also the rationale. There is another question, and there is another answer. There is another question, and there is another answer. And if you don't understand the rationale of these questions, then you can email me. Okay, that brings to the end of our pain um, presentation. It's a very vast topic, and I'm trying to make it manageable for you, so you understand the most basic concepts. Okay. Okay, thank you.